So thank you very much to Jenny and the Closer team for inviting me to give an overview of Born in Bradford cohort study. So what I wanted to do in this brief sort of overview is to give you a little bit of understanding about the aims, context and ethos of the Born in Bradford cohort, and give you some case study examples of how you can use various different types of data that we collect within the cohort, from the traditional biomedical to routine to traditional questionnaire type data to answer specific questions that will be relevant from a social science perspective. And the strapline I've got on my first slide here is people-powered research. And that is, if I was to encapsulate what Born in Bradford is all about, it's about trying to empower communities and make things better for the families that live in Bradford, but also families across the UK and internationally. So I can't give you a talk about Born in Bradford without giving you a little bit of context about our place. So as you will have guessed, Born in Bradford is a birth cohort study which is set in the northern city of Bradford in the beautiful Yorkshire Dales. And Bradford is an amazing place to live and work, and I have lived and worked here for longer than I care to remember. We are a very vibrant and multi-ethnic city. So at the last census, 2/3 of our population identified as white British, and around 25% of our population identify as South Asian, and many of the communities come from Pakistan. So we've got very large rates of ethnic density within our city. We're also a very young city. We have one of the highest birth rates in the UK and a very young population. And in fact, when we look at women of childbearing age in the city, we actually find that it's more like 50% of births in the city are to families of South Asian heritage. And I would advise, once lockdown restrictions ease, I invite you all up to come and have a look at our city, because it's really beautiful, and it often gets a bad press. But it's fair to say that Bradford's not without its challenges. Like any post-industrial urban city, we have pockets of very, very high deprivation. This is a slide looking at the English indices of deprivation. And the take-home message from this slide is that if you look at quintiles of deprivation across England, over 1/3 of Bradford residents are in that most deprived category. And we know in terms of health and well-being and educational outcomes, deprivation is one of the most pernicious problems that we have as a society. And you can link high levels of deprivation to pretty much any health outcome, and you will find that it will be one of the key predictors. So this was the context in which Born in Bradford as a research programme kind of came into being. So we set up around about 2006, and the aim was to really use the study to work with stakeholders, health professionals and communities within the city to sort of put an observation glass on what is going on and trying to disentangle the factors that keep some families healthy, and the factors that make some other families fall ill. But we are not a dusty shelf academic research project. We're not just there to sort of look and see what's happening. We're there to try and make positive changes. So a second key aim of the Born in Bradford cohort is to use the findings to actually make positive changes within the city, whether that's applied health interventions or changes to policy, or working with education specialists. We have a very practical and applied focus. A third aim for us is to build research capacity, both within the city, but also further afield. And to that extent, we are a very collaborative birth cohort, and we welcome applications from collaborators across the UK and internationally to come and use our data and work with us on projects. And the final aim for us is about showing how you can make that link between research and practice. So trying to do stuff which is very useful, which then has a higher probability of being implemented. So between 2007 to 2011, we recruited over 12,500 mums to our project. So these were mums who were pregnant and booked to give birth at the city's main maternity unit in the centre of Bradford. And over those 12.5 mums had over 13,500 children. And I'm very proud to say that I managed to squeeze 2 children in the recruitment period. So I'm also a born in Bradford mum, and probably have 2 of the most highly researched kids in the whole of the UK. What's great about working on a birth cohort study is things never stay still. Okay, so once we'd got through the initial recruitment period, we were very focused on birth outcomes and hospital and maternity, and then all of a sudden our children started attending primary schools. These are some pictures of our cohort participants on their very first day in reception, and it was that where we really started to mark a shift from looking at some of the more traditional health research to actually getting involved in much more multidisciplinary health and education. So with some of the schools across the city, you will have maybe 90% of children in particular classes will be born in Bradford children. So an awful lot of important work that we can do with our partners there. This is our oldest child, Ibrahim, who's actually now 13 and a lot taller than he is in this picture. And we've got a great picture of him with his mum, and he's towering above her. But what's been really great in the sort of recent history for Born in Bradford is that, our young people are now starting to enter secondary education. And so are taking much more of a steering role in shaping our research project and the priorities that we have moving forward, which is very, just very exciting for us. I should have mentioned earlier that one of the sort of unique elements of our birth cohort is our ethnic diversity. So amongst our 12,500 families, around 45% are of South Asian origin, South Asian heritage, and around 40% are of white British heritage. And this means that we are able to look at ethnic differences in a much more nuanced way that perhaps we can't do with other cohort studies where the numbers are less. So what data do we have available? Well, the brief answer is we do have an awful lot of data on families who are enrolled in Born in Bradford. And this figure just summarises the key bits of data that researchers can come and ask, request access to. And the web page at the top is where you can get a lot more detail. But essentially, we have lots of questionnaire-based measures. So this comes under our direct observation. So we have questionnaires at baseline when we recruited mums, and also questionnaires at subsets for different parts of the cohort at key developmental milestones and life stages. One of the sort of key successes of Born in Bradford has been our ability to link to routine data sets. So when mums agreed to take part in the study, we asked for their consent to link to health and education data. And we have linked health data for 98% of our cohort participants. So this will be things such as what's in your GP record, what's in your maternity record, health visiting records. And we have 84% linkage to education data. So some of our young people have gone to school out with Bradford, but for the kids that are stayed within Bradford, we can link to 84%. And this means that we have access to anything that's collected at a school level. And I think quite unusually where the real strength of BIB is by sort of combining that traditional social science data with a lot of really cutting edge health data as well. So we have a biobank where we have over 10,000 blood and DNA samples and urines, and these are available to be accessed by researchers. We have metabolomic data and also genomic data as well. And what this means is that this wide array of data means that you can actually start to take a really holistic view about predictors of health and well-being. And coming soon, we've just finished our most recent follow-up of the cohort when our young people were aged between 7 and 11. Unfortunately, that has been disrupted quite substantially with the pandemic, but we're hoping that data is going to be available to use to researchers in the next year or so. So there is an addendum to the data set coming up. And what have we researched? Well, if I was to take you through all the findings. We'd be here till the weekend, so I'm not going to do that. But just to give you a sense of the breadth of research in BIB, we've looked at everything from acrylamide, which is a chemical that is formed in food when you fry food in very high temperatures, and that's been linked to low birth weight. We've done lots of work around air quality, looking at links between pollution and birth weight. And then right on the other spectrum, we've been looking at green space, right through to gene knockouts using our genomic data. So a really wide variety there. And if you want more information on any of that, you can access our website. We have all of our key findings on there. But I wanted to now just very briefly kind of give you 2 case study examples of how you can use different elements of the Bourne and Bradford data to answer research questions. So the first example I'm going to give you is based on the work of my amazing colleague, Stephanie Prady. And she was interested in looking at common mental disorders during pregnancy, and if there were any ethnic differences in both the prevalence of these common mental disorders, such as anxiety and depression, in terms of both prevalence and how they are treated. So the key references are on the screen here. And what we used for this study is our baseline data set, so our very rich questionnaires that we did with mums during recruitment, which had measures of mental health. So it was the general health questionnaire and other measures of anxiety and depression, which provide a sort of self-report of women's mental health at the time of recruitment. And we were able to link that data with maternity healthcare record. So we were interested to see if what common mental disorders or treatment were recorded in the maternity healthcare record, and also then the GP record. Now, the sort of overall estimated prevalence of mental ill health in the perinatal period and immediately postnatal is around 20%. That's what sort of the standard levels are. Now, when we looked at what was recorded in women's medical records, so this is from maternity and GP records, looking from pre-birth to 3 years postnatal, you can see very wide ethnic variations in the prevalence that is coming out through this routine data. So we can see that there are many more white British mums who are recorded as having problems with common mental disorders. But when we contrasted that to our self-report data, we realized that it was a massive underestimation. So our self-report indicated that over a third of women were reporting severe mental distress during pregnancy. So the first interesting thing here is, right, okay, well, this isn't making it through to our healthcare systems. And the second thing is here is, well, what's going on? So why is there much higher prevalence amongst white British than Pakistani women? So what we did then was to look at, right, those cases that are missed. So what we were able to sort of ascertain is that around 50% of cases of problems with mental health are potentially missed. So they are not making it through to healthcare providers. And there's a massive disparity in the majority of missed cases are amongst ethnic minority groups. So this has real implications for service provision. And then what we were able to do is just to go a little bit further then to say, okay, well, what happens with the cases that are turning up in primary care? What's happening to these? And this is a graph that shows you treatment that has been recorded in healthcare records. And you can see here again that there's very wide variations in what our white British versus our ethnic minority families were receiving. And if you look at the bars on the right hand side, we find that actually much higher proportion of ethnic minority women were not receiving any treatment at all for their common mental disorders, quite a marked difference there. And a substantial proportion were receiving than white British were receiving less access to pharmacological and non-pharmacological interventions. So these results have been used and been working with our healthcare providers and clinicians to look about, right, how can we improve treatment pathways for women who are experiencing common mental disorders, especially from ethnic minority backgrounds. So I hope that that's given you one example of how we can combine these different elements of data. And I want to take you now onto a completely different case study, just to, again, it's just to give you an idea of the breadth of the work you can do. So this is a research area which is of my own particular interest, around environmental determinants of health and well-being. So we were interested, there's a lot of literature now that shows that green spaces are really important for mental health, mental and physical health. So this, you can see here, has got a bit of a pixelated map, but this is a map of Bradford. And this is a map of Bradford in terms of how green the environment is. So the bits in lilac are parts of the city which have much less green space, and the bits in dark green have a lot of green spaces. And what we wanted to do was to look at whether where you live has an impact on the birth weight of your children and maternal mental health during pregnancy. So what we were able to do with the data that we have within Barn & Bradford is to first of all think about, right, what are two outcomes, so depression during pregnancy and low birth weight, which were collected via questionnaire sources and from health records. And we were able to think about all the different confounders that might confound relationships with our outcomes and control for these in our analyses. So if we think of it like a big spider's web, we were able to control for ethnicity, parity, health, age, deprivation, education levels, wealth, but also health behaviors as well, such as alcohol, physical activity, drug use, and smoking. So we were able to sort of take all of those into account to try to disentangle what the unique impact of green space might be on health and well-being. So what do we find if we look at maternal depression? First of all, we find that those living in the greenest areas of Bradford were between 18 to 23% less likely to report severe depression during pregnancy. But what was very interesting is that we only found this relationship for families who lived in the most deprived parts of Bradford. And we also find that the sort of positive effect of green space was much stronger for women who were already active, so presumably women who are already out and using these green spaces. In terms of birth weight, we find, again, sort of really clear links. So we find that the greener the environment, the healthier weight of babies. So for every 10% increase in greenery, as assessed by this satellite measure, there was an extra 16 to 22 grams of birth weight. But again, interesting that this was only for white British, but not South Asian women. And so I guess the take-home message is that the quantitative information will get you so far, but there is still a lot of additional work that you might need to do in order to really get to grips with the nuances of the findings. So based on this work, we started to do a lot of qualitative work with families looking into things like satisfaction with green spaces and barriers and enablers to green space use. And those findings are in fact being used by the city in a project called Better Place, which is aiming to implement co-designed green space improvements for families living in some of the poorest parts of Bradford, and will hopefully be able to explore whether they do indeed have an impact on health. Okay, so those were my two examples, a very whistle-stop tour. But really, in terms of, how do you get involved in Born in Bradford? Well, our vision is to promote a healthier and fairer future for children. And so we welcome any request for collaboration. If you have the same aims as us, then you are very welcome to come and join us. In terms of accessing data, we have quite it's not a massively onerous process. A web link here shows you a web address to access, which sort of outlines the process, but essentially we ask for an expression of interest which is reviewed by our BIB executive group, which meets monthly. Dependent on the data that you request, there will be a data access fee. So this will cover the time of our data team to prepare the request. And obviously, the more complicated the request, like if you're requiring screeds of routine data and lots of different follow-up points, then it will be a slightly more involved process for our team to help and work with you on that. I think that was all I wanted to say. I've got 40 seconds left. I think we've got a little bit of time for questions. I just wanted to leave on my favourite picture of the bib cohort, which are these twins in Bradford flat caps. So I think I'll leave it there.